Hello, Dr. Yanka.
Hello. Yeah, so let's pray.
Okay.
Heavenly Father, we thank you. We give you glory and honor for bringing us to today's session of learning. Father, we thank you once again for the season facilitator you've prepared for us. We thank you for the gift of life. Father, as we've gathered here to update our knowledge, Father, may you guide and protect us. This and many others, we ask you, your Son Jesus Christ, with thanksgiving. Amen.
Amen. And please, at this juncture, we'll call on Dr. Daniel to give us the welcome address.
Hi, Dr. Daniel, if you can hear us, you have to give us a welcome address. And by way of information, this meeting is streaming live on YouTube. And so those who are not available and cannot join us now can also follow the YouTube channel and have it there. Thank you. Dr. Daniel, over to you.
Dr. Jonathan, I think Dr. Daniel has gone off.
Yeah, I spoke with him. I think he's trying to join again.
Okay.
So by way of information, this meeting is still live on YouTube. I will be sharing the link very soon on the social media platforms. And then those who doesn't want the certificates and the CPD points can just write no CPD, no certificate at the ID column, and then you can access the link to the meeting. And so you are all welcome to today's meeting. It's going to be a very educative one. I'm sure maybe from there we can get into our world comfortably with new knowledge on asthma from our seasoned personnel. So get ready, get your questions and get your pen and papers with your questions down. I'm sure at the end, Dr. Saba will be telling us a story and how to pay our dues as members of Pediatric Society of Ghana as well. Dr. Saba.
Yes, Jonathan, thank you for mentioning my name. So thank you. Dr. Daniel is unable to join, so I'll quickly do the welcome address on his behalf and introduce our facilitator for this session. My name is Edem Saba. I'm the treasurer for the branch. And on behalf of Dr. Daniel, I welcome you all to this, who is our chairperson, I welcome you all to this CPD. As a young society, we like to equip our members with the skills to provide quality health care to the children that they see on an everyday basis. And we hope that this session will be very fruitful and useful to us and would impact outcomes in the region. This afternoon/evening, we are blessed to have our facilitator, who is Dr. Hilary Andor. She's a pediatric allergologist at the Greater Accra Regional Hospital, where she set up the first pediatric allergy clinic in 2024. She manages a variety of allergy cases ranging from allergic rhinitis, atopic dermatitis, chronic urticaria and angioedema, food allergy, drug allergy, and various severities of pediatric asthma, among other allergy-related conditions. Dr. Andor is a member of the Ghana College of Physicians. She obtained a subspecialty certificate in pediatric allergology after her 2-year subspecialty training with the College of Medicine of South Africa and has completed an MPhil in allergology with the University of Cape Town. She's a member of the Pediatric Society of Ghana and the president of the Allergy Society of Ghana. Dr. Andor has served as a faculty member of the World Allergy Training School and has been a speaker at both national and international forums on allergy, including asthma. Ladies and gentlemen, please help me welcome our esteemed facilitator. Thank you. Dr. Andor, your audience.
Thank you very much, Dr. Saba, for the for inviting me in the first place and the warm introduction. Can I be heard, please?
Yes, please, with loud and clear.
Okay, if at any point the connection is unstable, do let me know, and then I can either switch or reposition. So for now, thank you very much. I'll turn off the video in order to improve the bandwidth a bit, and then we'll kickstart. I hope to be done in an hour, and so let's see how it goes. Okay. So this late afternoon, I've been asked to speak on pediatric asthma management, and specifically, I've been asked to speak on building asthma teams in a district hospital, or building an asthma team in a district hospital, and then speaking about the management of acute exacerbation of asthma. So today we'll deal with the acute episodes rather. And our learning outcomes at the end of this presentation, I expect that we'll be able to know the practical ways to constitute an asthma team in a district hospital. We'll be able to differentiate between the severities of acute exacerbation of asthma. We'll be able to identify medications and some adjuncts in the management of acute asthma, and then some key points for discharge and follow-up. Then we can have some discussions and share experiences based on the different levels of care we work at. So asthma is a chronic respiratory disease with many variations and of many phenotypes. Usually it's characterized by chronic airway inflammation. We say it's heterogeneous. It's characterized by variable expiratory airflow limitation, that's respiratory symptoms. So you could have wheezing, shortness of breath, tightness of the chest, cough, and they vary in intensity and over time, and sometimes are seasonal as well. Globally, about 300 million people have asthma, and almost 500,000 deaths occur from asthma globally, annually. Now, about 96% of these asthma-related deaths occur in low and middle-income countries, of which Ghana is part. So today, building an asthma team in a district hospital is just part of that plan to help to reduce the outcomes I talked about in the previous slide. And the aims of building the team are actually to mainly provide comprehensive care, empower patients, and then improve outcomes in patients living with asthma. Now, when you want to build an asthma team, I must emphasize from the beginning that we don't need to overly think or expect that everything should happen at one time. So you can actually build in steps and then have timelines for which you can work within. You do not need a huge facility to build an asthma team. Depending on where you are, you can look at your situation in the clinic or the hospital. In this case, it's a district hospital. Look at the purpose of the clinic. Okay, the room is actually one of the key things you want to have. It shouldn't be an elaborate room. But what's the purpose of the clinic? Which groups of asthmatic patients are we targeting? And how much can the hospital take on, and how much can the clinic take on? And these come not only with infrastructure, but they also come with human resource, which is, I think, one of the very key aspects of building an asthma team. Okay, so the purpose of the clinic, how many patients are you targeting? What is the scope? Are you able to handle all severities of asthma patients? How do you plan to do the referral systems? And how many clinics per week you would want to run, or how many clinics per month you would want to run? And what is your aim, or what is the goal about how much percentage in reduction in morbidity or mortality are you looking at? And these are premised from data that you may have collected from previous morbidity mortality meetings and the rising incidence of asthma and asthma-related deaths. Now, with a team, you need a number of people. So one person cannot run an asthma clinic effectively. First of all, you need management or stakeholder support. Management is one of the key human resource you would need, because without management, you may be doing things in your clinic, but you may not be getting as much results as if you had involved management. So they need to know, first of all, to be able to even provide you the space or agree with which space has to be used for the clinic. In management would also be one of your cheerleaders, because if the clinic has to succeed and you need consumables, you need funds, you need equipment, it's management we are going to go to, because the head of the hospital has to be in the known, the nursing head, the finance head, because budgets would need to be submitted, procurements, they all need to know that you are starting something. Now, the human resource needed for the clinic. Here, I've put the doctor as a team lead, because I presume that in the district hospital, there would be a doctor or a physician assistant. So this doctor now coordinates what has to be done in terms of building the team. You need a leader for every team. The doctor may or may not be a specialist, but the main thing is that the person should actually be very, very dedicated to starting this this journey. You may add 1 or 2 more other doctors or a physician assistant if there's one in the hospital. The nurses are key in an asthma clinic team management. So 1 nurse or 2 nurses are really important because they are going to help a lot in education after clinical decisions are made. Now, the pharmacist is needed as well because, of course, with drugs being requested, stockouts, knowing which new medications have to be gotten, asthma devices that need to be purchased by the hospital, switching of therapies, the pharmacist is key in that as well. We need a records officer or a data analyst as well, because definitely you need some data. If later on you need funding for the clinic, or you'd need some equipment replaced, some consumables replaced, is the data you're getting from the clinic that's going to help build that app. Data is also needed just to also know your clinic attendance, those who are new patients, who are old patients, what they are coming with, what comorbidities they have, and then how frequently you have to review them. The community health workers are important in this team as well, because in the district, you would also have to do some outreaches. You may have to have some community linkages where there's a step down training to the community. Remember that we would be seeing them in the hospital, but some of them may be coming from quite far off and may not be able to visit the hospital at the times we want them to. And so you may have focused groups in certain communities where they can check on the patients and follow up. Volunteer peer educators are also important. These can come from the parents or caregivers of the patients in the clinic. And peer educators are found to be very helpful because a case in point, I have a patient or 2 who are close to the teenage years, really struggle with inhaler use or the device use, and are not so keen on using their devices. And at the same time, there's another patient who is really good at using his device and is up to date with his treatment. What I do sometimes is that I pair the 2 for the same visits. They've become friends of some sort because one is able to rub it off on the other on how to properly use their inhalers. Though we teach them, sometimes the peers actually even drive the information better. Then the caregivers also are good in sharing their experiences. Sometimes they get very positive experiences from others, especially if you have one patient with poorly controlled asthma speaking to another who was in that situation some months back, but has been adherent with follow-ups, adherent with medications, techniques. They pair up, and then you realize that adherence even improves in the other person. There may or may not be a respiratory therapist in the district hospital. If there is, then that person is going to also play a very key role in the team. Now, protocols, clinic documents, and guidelines are needed for the clinic. They may not be anything very elaborate. They can be just one-page documents, which don't need to be done at the same time. You can actually do these stepwise, but the basic things that are needed to start running the clinic. So protocols on maybe how to use the inhalers, step up, step down, clinic documents on appointment cards. So if you see the picture on the right, you can see that there's a container there, there's some appointment card in there. There's a tank depressor, there are spaces, different types, so that the patients can even relate to what you are talking about. Here are some documents up there. And then to the left, you see there's a file there. And then you can be building up the SOPs or the guidelines as the clinic continues to run. Training is important because the staff have to be trained. So the staff that are gathered from the beginning, whoever is the most experienced, especially in terms of inhaler technique, device use, and what to do with the patients, is the best person to do the training. And so that person carries the rest of the staff along, the clinical staff along. So the whole clinical staff for the clinic are abreast with what has to be done. So you do not have two different people giving conflicting ideas on how inhalers and spaces should be used. Training of also the records people and where exactly you want things recorded is also important. For the nurses, if there's more than one nurse, you make one the nurse champion, so he or he can be actually checking on the others, revising techniques on a weekly basis, or you can do even a monthly basis just to see how the techniques are being done again in the clinic. Equipment or consumables needed, you definitely need a room. It can still be the clinic, one of the consulting rooms in the clinic that is used for other things on other days. If the clinic is once a week, then that asthma clinic is designated for that particular day and period of time. When it's time for that clinic day, all the things needed in terms of protocols, documentations are put in the clinic. If there are pictures you need to put there, if there are dummies you want to put there, you put it there on that clinic day. You'd also need other consumables, equipment, so pulse oximeters, nebulizers, asthma devices, face masks, dummies. You need a stethoscope. A weighing scale is important because you need their heights and their weights, especially for children. That is one important thing for us. You need a sphig as well. Then peak flow meter with mouthpieces. If there's funds available, then a spirometer could be purchased as well. Then asthma medications, very important. So at least the first line medications, salbutamol, ipratropium bromide, that's the nebules, should be provided as well. Then educational equipment. So just as I alluded to earlier, pictures that you can just slot in the clinic file to be showing to the parents and to explain how the airway looks like, what the pathology of asthma is. The pictures stick better than just speaking to them without pictures. Then toys and play items. For pediatrics, you need that because the asthma clinic takes, you need quite a bit of time with one patient in terms of education. So it's not just about seeing the patient, taking a history, writing medications, and off they go. So whilst you are educating the parents or the caregivers, you can have their full attention when the children are also distracted, especially the little ones. For the older children, those above 5, 6, 7, they can join in the discussion because a lot of them are actually keen on knowing what is happening to them. Now, action plans are important to be placed in the clinic stock as well. So any action plans, asthma diaries, these can be very simply done. You can create an Excel sheet and just put a date, the name of the patients, dates with the months, and then have the full month. So a 31 day box, and then just type in the days, the dates, and then you only keep filling the months. So they're able to tick when they are given their medications. The action plans that are colored also help a lot. Then a clinic attendance book is needed, as I talked about earlier, for record keeping. That clinic attendance book, you could even have two. So one of them can be your regular attendance book. The other one can be an appointment book where you make keynotes of what you need to do for particular patients on the dates they are coming. I found that very, very helpful. So apart from the regular A&D books that we have as the standard clinic books, if you have a diary where you write patients A, poorly controlled asthma, needs a step up on this day, patient B may need to step down. So even before the patient comes, you have an idea how the clinic is going to look like that day, who are the patients you may need to spend much more time with, how you distribute them amongst the doctors based on competence, and then who you even want to teach more that day. And then the patients you think are already abreast with their treatment plans. So appointments help a lot. I see that most of the time what we do is we just say, see at asthma clinic, see at asthma clinic. But when the clinic is packed, it actually reduces the duration of time for patient education. Because let's remember that with education, two asthma patients may be using the same device, but may not be able to get the technique at the same time. Then a TV for patient education is also good, where you can keep replaying the education videos. So these are some common examples. These are real life clinic pictures from our allergy clinic. So it's for all the patients, but then these are the ones related to asthma. So you just drop toys there so that whilst you are explaining things to parents or caregivers, the little ones are playing, and then the parents can pay attention to you, because sometimes they get really distracted. Then you have a box where you have the different spaces that you use for demonstration, which they can relate to. And then on my right, you see there are different types of asthma devices in there. Because for some of them, they come and tell you we are on the brown one. You are not sure whether they are on beclomethasone or they are on budesonide. They come and tell you we are on the red one. You are not sure if it's red and white or it's just another color. But some are able to point at the specific inhalers and tell you, this is what you gave me. And it is always advisable to encourage the caregivers to always come to the clinic with their devices and the modes of delivery. So the spacers, if they are using spacers as well, because those will be used again in the clinic for every clinic visit. Even for the patients who are abreast with their treatment and have had good inhaler technique, you always go over the techniques with them, because what I have found that's real is that for patients who have not had any exacerbations in a long time, actually tend to forget how to even use their inhalers, especially those who are on as needed reliever, anti-inflammatory reliever treatments. So again, just finishing up with the building the asthma clinic bits, you look at the flow of work. So how are you assigning roles? So in the room, in the clinic you've identified, where would the triage area be? Who is going to be in charge of triaging? Is it a specific nurse each time? And then who would weigh, who would write out the values from the triaging? Where do they go? And who leads them there? Because sometimes you have one long clinic space, there are multiple rooms. And so if you don't have a clear system where the patients know which rooms they are going to, you see them moving from room to room or joining the wrong queues. So another good thing that happens with the appointment system is also that you can easily you can easily tag their cards with color codes so that they know that if I'm using orange for asthma clinic, anyone who is triaging on that day sees orange and knows that I'm coming to the asthma clinic. So you don't go and join another clinic for that day, only to realize that you've wasted your time. Then who does patient education? So as I said, this is not about who is the most experienced in terms of grade. It is about who is passionate about education and who can do it best. Because what we all want is for the best outcome of the patient. Then where do the patients sit when they come? Are they sitting far off from the clinic? Do they have to be called in one at a time? Or are they lined up in front of the clinic? If they are lined up, how do you manage who goes in first, which doctor sees, and where they go for the education? Then the clinic days and times that I've talked about, that depending on the district hospital and depending on the loads, if you see there are going to be long queues, you can decide to batch the patients and say that from probably 9 a.m. to 12 noon, this group of patients should come. From 12 noon to this time, these patients should come. Or as happens in a lot of facilities, they all come at the same time because there are real issues with traffic or it's rained. And so the people you've booked for the morning may end up appearing in the afternoon. Then the scheduling of appointments requires time and commitment. So some practical things are that you can get a phone where you actually send the patients a reminder that tomorrow is your clinic day. Those who won't come would actually, a number of them would get back to you and say, my child has exam, sorry, I can't come. This is helpful because it can then let you actually rebook them and also refill their space with another patient who you had wanted to fit into the clinic. And it also avoids that rush of patients who come in and haven't been booked. The one doctor or so in the district hospital is overwhelmed, and then you realize that patient education does not go well at all. Now, managing the acute cases, what happens? Where do they go when they have their acute problems? Who do they contact? Do they come to the emergency directly? Is there a contact number they call? And then after the acute case management, how is the flow? Have you liaised with other units within the hospital where they go for the 1 to 3 day post-discharge follow-up, after which they come back to the chronic follow-up? Or are you seeing them directly in the chronic follow-up clinic? So if you are seeing them directly in the chronic follow-up clinic, that space should also be made available so that whilst you are booking chronic follow-up patients, you know that you are going to fill in with some acute follow-up patients as well. Then lastly, I talked about a records officer or data collection person. So what are you going to be using to collect your data? Now we have the electronic medical records. So that is if you want to have a backup file for the clinic, that's also important. If there are specific things you want to collect about patients, those can go into the data collection as well. And whoever is mandated to do that should know what happens in the clinic and what data exactly the clinic is interested in. The community outreaches or engagements I talked about earlier. The clinic staff can then liaise with some of the community health workers to be able to follow up on patients post-discharge and for chronic follow-up. So now that ends my first presentation on building an asthma clinic. I'll move straight on to acute exacerbation of asthma. So acute exacerbation of asthma refers to the episodes of worsening symptoms, shortness of breath, wheezing, chest tightness, and cough, and or decline in lung function compared to an individual's usual status. That is often sufficient to warrant a change in treatment of the patient. Then acute asthma can have a significant impact on morbidity, and in some cases, deaths can occur. According to World Health Organization, the 2020 data, in Ghana, about 4 to 5 deaths occur daily from asthma, and that's about 13.95 per 100,000 population. So 4 to 5 deaths is scary. That means in 5 days, about 20 people would have died from asthma. So that is actually maybe the size of a class in some schools. Now, the pathogenesis of airway inflammation, I'll briefly go through this. So you have the allergic and then the non-allergic and neutrophilic inflammation. Simply, the allergic ones, you have the allergen, let me use my pointer. So you have the allergen there being presented to the dendritic cell, which in this case is the antigen-presenting cell, and then to the naive T cell. Then this naive T cell, now receiving the allergen, differentiates into the Th2 cell. Then with that, you have a resultant class switching of the B cells to IgE, and then to the mast cells. Then with subsequent exposure, we can have the mast cell degranulation, producing that allergic response. Then we also have, and these are mediated usually by interleukins 4 and interleukin 13. We also have interleukin 5, which is very important in eosinophil maturation and then getting eosinophils from the bone marrow into the systemic circulation. Then we have the neutrophilic inflammation, and this one mainly has Th17 being involved. So not all asthma is just allergic. You can have neutrophilic asthma as well. Now we also have the early and late phase responses. This is when you have the acute, I'm talking in respect of acute exacerbation of asthma. So here you have release of inflammatory mediators, like I talked about. You have the leukotrienes, you have prostaglandins, histamine, release of nitric oxide, leading to airway inflammation. And this now results in hyperresponsiveness of the bronchioles. And that's when we have that bronchospasm in asthma. So the bronchospasm is early enough, usually about 30 to 60 minutes after the exposure to whichever trigger there is. Then the late phase response. So this happens about 4 to 6 hours after the early phase response. This late phase response could either be a worsening of the symptoms that we found in the early phase or a recurrence of the symptoms. So the patient could have been getting better and then suddenly worsens, which we actually see in our day-to-day management of asthma. Then there's bronchial constriction, there's epithelial desquamation, there's mucus production, then there's increased edema. And then there's reversible obstruction, air trapping, dead space. So I'm talking about this now because when we come to the management of acute asthma, some of the medications, especially the corticosteroids, help in reducing the late phase response of asthma. Now, some of the risk factors for exacerbation of asthma are triggers. There may or may not have been any known trigger at that time. Sometimes the triggers may be irritants or allergens. So you may have had a very well-controlled patient with asthma who immediately appears with severe or life-threatening asthma just because they have been in an environment where somebody was burning rubbish and that triggered their asthma. So the fact that you've had apparently mild asthma does not rule out the fact that you can actually have a severe exacerbation of asthma. The allergens are not the allergens are specific to that individual. So some allergens could be cat's dander, dog dander, house dust mites, and these are specific for that patient. So not all asthmatics would have, for instance, house dust mites as their allergens. Now, over-reliance on salbutamol and other bronchodilators is a huge risk factor for exacerbation of asthma because overuse of salbutamol actually causes worsening of bronchoconstriction. And it's been seen that for patients who use about 3 canisters of short-acting beta agonists per year, have actually an increased morbidity from asthma. And if you are using 12 or more canisters per year, it actually increases your risk of asthma death. Then poor technique. Poor technique is one thing which is very, very modifiable that we can work on. So those with poor technique risk exacerbation of asthma, especially if I want to use an example, let's say a 4-year-old who has been prescribed a dry powder inhaler. The force needed to actually inhale using the dry powder is much more, is stronger than actually using a pressurized metered dose inhaler with a spacer. So prescribing asthma devices should be looked at very well when you are managing the asthma patients. Then also spending more time in patient education. Let's not assume that because the patient has a relative who has asthma, they can also use it. For all you know, they are using the wrong technique. And even if the person is a health worker or the caregiver is a health worker, always go over the technique. And this is something I'm so keen on because every clinic visits, review the technique or look at them perform it, and then revise if they are not doing it too well. The poor technique can lead to the medications not really being delivered effectively to the lungs. Then the lack of or inadequate use of inhaled corticosteroids. So now GINA guidelines advocates for inhaled corticosteroids when you are using short-acting beta agonists and inhaled corticosteroids for the different phases, the different steps of chronic asthma management, even with adolescents who are infrequent wheezers, who are on step 1, are on anti-inflammatory reliever therapy. So now we do not have SABA only for asthma patients. Then those who have poorly controlled asthma risk exacerbations. Those who are poorly adherent with their asthma medications also risk exacerbations. So our objectives of management are to objectively assess and then categorize the severity of exacerbation. We also aim to provide immediate and effective treatment in order to achieve symptom relief, decrease respiratory distress, and improve oxygenation. We also aim to initiate or adjust controller treatments so that we are able to achieve or maintain the control of symptoms, thereby improving quality of life and then able to help the patient with an action plan. The key points, some key points in acute management of asthma. Remember that when they come acutely, first things first, we need to assess, do a quick primary survey. You can take a history whilst you're assessing the airway, breathing, circulation. Oxygen saturation is important, but if you do not have a pulse oximeter, don't waste too much time going from ward to ward looking for a pulse oximeter at that time. Look at the patient's work of breathing, and then look at some other parameters I will talk about. If the patient is obviously in respiratory distress, start oxygen. Do not wait for pulse oximetry. Then if there's a peak flow meter available, check peak flow if the patient is able to blow. Now, is this really asthma or not? So sometimes we would hear the patient has come with an acute asthmatic attack, but think about differential diagnosis. Is this a patient with an inhaled foreign body? Is this patient in heart failure? Is this patient one with cardiac tamponade? And probably, is it not asthma? Okay, some vocal cord dysfunctions can also present just like an acute asthmatic attack. So listen, examine the patient, listen to the history, and then decide whether you are dealing with asthma or you may be dealing with something else. Then look at the risk factors for asthma-related deaths. So in that, whilst you are managing the patient, you're also taking a history alongside. Is this a patient who has been to the ICU before? If this is a previous ICU admission, then you must be on the high alert because they can have another life-threatening attack. Then assess the severity. So use the West feature to classify, and prompt initial treatment is key in asthma management. Prompt referral is also key. Then the first lines are the bronchodilator therapy. So a short-acting beta agonist in our setting is salbutamol, plus or minus ipratropium bromide. Oxygen therapy if indicated. Corticosteroid therapy. Now the GINA 2025 guidelines do not, they are not big on corticosteroid therapy for mild asthma. But if the patient is not improving, it is needed. A lot of the protocols still use the corticosteroid therapy once the patient has arrived in hospital, because once he's in hospital, it is very likely that they've been trying at home and not achieving control, and that is why they are in hospital. Then titrate the oxygen based on response. Decide whether to admit or not to admit, and this is individualized. And then you do not need routine chest x-rays or routine antibiotics for asthma management. The history would tell what to do. If there's blood gas, if there's a blood gas analyzer in the hospital, a blood gas can be done, but this is reserved usually for the severe and life-threatening asthma episodes. Then the planning for discharge and follow-up. So the classification, looking at a number of protocols, there's a mild to moderate asthma. A few protocols will still subdivide into mild and then moderate, but mainly it's mild to moderate. And you need, under mild to moderate, the patient is able to complete sentences in one breath. You'd see them preferring to sit rather than lie down. the respiratory rates may be increased. In the mild ones, they may not be increased. There's a use of accessory muscles of respiration. The saturations, if we are able to check, which we should have pulse oximeters around, is more than 94%. The pulse is usually less than 120 beats per minute. And if the patient is able to do a peak expiratory flow, 50%, more than 50% predicted or personal best, and the air entry will be good. Then with a severe asthma, even if you get one of these parameters, they should be classified as severe. The patient is unable to complete sentences in one breath, sits hunched forward, there's increased respiratory rates, there's a use of accessory muscles of respiration, saturations are lower than in mild to moderate, so now we are talking about less than 92%. The patient is agitated, there's tachycardia, there's peak expiratory flow rate, which is now less than or equal to 50% of the predicted, and they are unable to talk or feed because they are breathless. They may have pulsus paradoxus, and then there's reduced air entry. Now, with the pulsus paradoxus, it's a decrease in the systolic blood pressure more than 10 millimeters mercury during inhalation. Then with the life-threatening asthma, also one or more of the following parameters qualifies. If the patient comes in coma, poor respiratory efforts, an impending respiratory failure, cardiorespiratory arrest, or the saturation is less than 80 or cynosed. The peak expiratory flow rate, a lot of the patients in this category may be unable to perform a peak expiratory flow measure. The patient may be drowsy or confused. The chest is silent. So look at the patient. If the chest is silent, it doesn't mean nothing is happening. It means that the lung delivery or air delivery to the lungs is a problem, and the obstruction is severe enough that you are actually not hearing anything. So a silent chest is a really, really, really high red flag in asthma. Then hypotension is another. Now, I put here some red flags for the respiratory rate and pulse rates in children, since it differs within the various age groups. So if you have infants, if the respiratory rate is more than 50 cycles per minute, or the pulse rate is more than 160 beats per minute, 1 to 5 years, respiratory rate more than 40 cycles per minute, pulse rate more than 140 beats per minute, or in more than 5 years, respiratory rates more than 30 cycles per minute, then the pulse rates more than 130 beats per minute. In 6 to 8-year-olds, respiratory rates also more than 30, pulse rates more than 120 beats per minute. This gives you an idea of whether the patients are tachypneic or tachycardic. Now, indications for PICU admission. Any patient with acute severe asthma who is not responding to maximal inhaled reliever therapy and systemic corticosteroids needs to be in the ICU. If the patient is hypoxemic, there's deteriorating mental status, the chest is silent, or despite oxygen delivery, the saturation remains less than 90%. Or this patient has the blood gas done and the PaO2 is less than 60, or the PCO2 is more than 34 millimeters mercury, this patient needs to be in PICU. If there's cardiorespiratory arrest or altered sensorium, like I said, needs to be in PICU. Now, the medications, the first line also differs from guideline to guideline in terms of the doses, but the medications used for first line are generally the same. GINA recommends salbutamol plus or minus ipratropium bromide. And these are some guides to how much in terms of the dosage that's used. So less than 5 years for salbutamol, we give 2.5 milligram, 5 and above, we give 5 milligram. Ipratropium bromide also overlaps. Less than 5 years, generally would use between 125 microgram to 250 microgram, and above 5 years, 250 microgram to 500 microgram. And the maximum should be 1 milligram per day. Then nebulized budesonide, 0.25 milligram to 0.5 milligram, 12 hourly. This is a wide range, but most protocols may use above 5 years would end up giving 0.5 milligram 12 hourly, but actually depends largely on the center in which you are. So with that, the maximum should also be 1 milligram. Now, how do we manage acute exacerbations of asthma? I've just divided it into the oxygen administration, the reliever would use, and then the corticosteroids. So this is a broad one showing all three: mild to moderate, severe, and life-threatening. I would break them down in the following slides. And so with a mild to moderate, we need to aim at an oxygen saturation of at least 94%, intranasal oxygen if indicated. And as I stated earlier, if you do not have a pulse oximeter or the patient is obviously in severe distress, please start on oxygen, because typically what we have in our hospital settings are probably one pulse oximeter or one monitor going around a number of patients in the emergency. And so you would not know at which point this patient's oxygen saturations may be dropping. Then the reliever. So for mild to moderate, when the patient comes in, we know sometimes we may not have the nebulized salbutamol available there. The ideal is actually to have your crash cart, which has your nebulized salbutamol, has the ipratropium there. But in the event that the patient is now going to get it, or the nurses are going to get it, or the doctors, if the patient has his inhaler and spacer, please start with the puffs whilst you are even trying to get the items for nebulization. So you can start with salbutamol inhaler, 4 to 10 puffs every 20 minutes. Usually for the patients who are below 5 years, we tend to use 4 puffs for them. Above 5 years, you can do 6 to 10 puffs. And remember, some people feel the puffs are too many, but remember that each puff of salbutamol is just 100 microgram. So 4 to 10 puffs with a spacer every 20 minutes for the first hour. Then assess the response at 1 hour or earlier. If you're in primary care and the patient is not improving or worsening, you have to start arranging transfer to a higher facility. Whilst the referral process is being arranged, do not stop the inhalations or nebulizations. You are reviewing the response at 1 hour or earlier. Earlier meaning that that patient may be deteriorating even before the 1 hour, despite being given adequate amounts of bronchodilators. Alternatively, use the nebulized salbutamol 2.5 milligram to 5 milligram every 20 minutes for 1 hour. Review the response in an hour or less, and then review the nebulizations depending on the response. Here, different hospitals use different protocols, and looking through the different protocols online by various facilities, including the worldwide guidelines, there isn't specific times for further review on how many hours you should space it, because you are looking at the patient before you. If you think that the patient is way better, you can do 4 hourly. In some instances, the patients may have to have it much earlier. So some protocols will have repeat after an hour, repeats 2 hours after, and then 4 hourly. The important thing is that that initial every 20 minutes of nebulization should go in, because we actually want to be prompt in the initial management to be able to review and recategorize our patients and decide whether this patient may even need to be stepped up, whether we need to refer, or we may need to scale up our nebulization or add an adjunct. So with the ipratropium bromide, it's not recommended in the mild to moderate episodes, according to Gina. We'll go up to the next one. Then corticosteroids, here in the Gina guidelines, like I said, for the 2025 one, you may not need to give oral prednisolone in the mild ones, but if you do need to give it, you can go ahead and give it. The reason is that because now the inhaled corticosteroids are part of the maintenance management. For example, if you happen to find the patient come to the OPD, he's playing around, he's not in, his respiratory rates are not high, he's completing sentences, he has a mild wheeze, he had a respiratory infection and has a mild wheeze, otherwise he's fine, you can actually step up his inhaled corticosteroid. But if you need to give oral prednisolone, then 1 to 2 milligram per kilogram per day. In pediatrics, the maximum is 40 milligram per day. Then for the severe, the oxygen should be administered. You may step up if this patient is worsening. Either you step up from the nasal prongs to a non-rebreather mask, or the patient may be going into life-threatening, and apart from the non-rebreather mask not working, you may now need to do non-invasive ventilation. Then the relievers, it's still salbutamol again. Now you add ipratropium bromide every 20 minutes for 1 hour. And I must state here that there's always this conflicts about whether to add saline or not add saline to the medications we are given. So the recommendations from a number of protocols is that you need the fill volume to be about 4 mils, because that nebulizer chamber has a dead space. And so you actually do not want to increase that dead space. So if you are using only salbutamol in this case, then fill the volume with saline to 4 mils. If you are using salbutamol ipratropium and your volume is up to 4 mils, it's fine. Nebulize every 20 minutes for 1 hour. If there's no improvements, you transfer to a higher facility, but whilst waiting for transfer, repeat the nebulization. Then in a tertiary care facility where you have access to an ICU, or you have access to personnel who can adequately manage severe asthma, then you may now need to step up to IV magnesium sulfate. I have the doses on the first slide with the summary there. In MAG sulfate, you are not giving it just as neat MAG sulfate. You need to dissolve it or dilute it. And so the dose is usually 25 to 50 milligram per kilogram. In some protocols, you find 25 to 75, but we typically would use 25 to 50 milligram per kilogram, dissolved in about 20 mils of normal saline, and run it over 20 minutes. Some people dissolve in 30 mils normal saline and run over 30 minutes. The important thing is that though you are given that as a bolus. It's a slow bolus because you do not want all the side effects of MAC sulfate. Then you need to continue the nebulizations. So even though you are administering MAC sulfate, the bronchodilators that you started with should be continued. In some centers, they may just be doing the continuous one. So they are refilling and giving the salbutamol again, even whilst the patient is on MAC sulfate. In Ghana, we usually would still refill the chamber, which is fine. But after that initial 1 hour of nebulization, you give your MAC sulfate if he's not improving. Give the nebulized salbutamol with the ipratropium bromide again, and then you can review to 4 to 6 hourly. In a number of protocols, after the first 3 doses of ipratropium bromide, which is for the first 1 hour, it is recommended that you review the ipratropium bromide to 4 to 6 hourly, because I mean, it also has to be given with care in patients with narrow angle closure glaucoma. And so the maximum dose of ipratropium bromide that should be given within a 24-hour period should be 1 milligram. We sometimes overdose, but that's actually the recommended. Then regular review in every patient with acute asthma is very, very necessary. When it comes to the corticosteroids, you can either give the patient oral prednisolone, or if they cannot swallow, give IV hydrocortisone. And then whether to add nebulized budesonide or not, I have a slide to discuss that. But you can add nebulized budesonide, and I gave the doses much earlier on. With a life-threatening, here we are actually running towards ICU then. So here you need to resuscitate, manage the airway, use a non-rebreather mask because we actually want to increase oxygen delivery. The respiratory supports, we may need a non-invasive. It's only very rarely that patients with asthma need to be intubated. It's actually the guidelines are actually more keen on non-invasive ventilation to improve outcome. Then nebulized salbutamol is still needed to be given, salbutamol with ipratropium bromide. This time the patient is going to be on IV magnesium sulfate infusion. In some centers that can access IV salbutamol, if after 20 minutes of MAC sulfate, we are not getting any improvements, they are going to be given IV salbutamol. And that dose is 15 microgram per kilogram in 10 mils of normal saline, given over 10 minutes. The maximum dose for salbutamol is 250 micrograms, so we don't go beyond that. That is not very much available in Ghana. It's actually difficult to get, but in the past few months, I've been able to use it for one patient who had near fatal asthma. Then continue nebulizations as per clinical state. Then the corticosteroids here, we are given hydrocortisone because obviously the patients in this state may not be able to swallow. Then we can add the nebulized budesonide. So here's the slide I talked about whether to combine or not combine inhaled and systemic corticosteroids. In some centers, they do not give inhaled corticosteroids together with the systemic ones, but the evidence is inconclusive. So I looked at a few studies and realized that for this one, that's by Magli et al., they said considering it's limited, they had just 50 patients and compared those they used the combined as against systemic corticosteroid alone, and realized that the association of nebulized budesonide with hydrocortisone hemisuccinate has no additional effect over the use of hydrocortisone alone in adult patients with acute asthma. A lot of the studies were done in adults, a few in pediatrics. Then this one by Sawanyawisut et al. Found some benefits in reducing the risk of hospitalization in moderate to severe asthma. Castro et al. Found no difference in admission rates, but they realized that the length of hospital stay had significantly improved with the combined one. So again, this is not a hard and fast rule. It depends mainly on the center and what you choose in your protocol. Now to discharge and follow up. Let's remember that after managing these patients, we are not going to leave them alone. They need to have an action plan to go home on. And this is really individualized. So if I have, for instance, if I have a patient who has been on nebulized salbutamol and ipratropium, we've stepped down to only salbutamol, withdrawn the ipratropium, chest findings are getting better, patient is getting better, and we need to discharge. You can let them go home on the metered dose inhaler or their anti-inflammatory relievers. You can have a step-down plan, and I say individualized because some of them may have been on 6-hourly nebulization and they are going home. They can continue the puffs for that day 6-hourly, and then you review to 8-hourly the next day. If they're on 4-hourly and they are going home, you listen to the chest, you think they need to step down to 6-hourly, you can do that. If you think you want them to go on 4-hourly, you can guide them on 4-hourly that day, 6-hourly the next day, and 8-hourly, and stop. The important thing here is that we need to let the patients know when to stop the short-acting beta agonists, because sometimes we discharge them, but they don't have a discharge plan. So they come back for follow-up and they are still using the short-acting beta agonist for about a month because nobody has given them a plan. And it is very important that before you discharge a patient with asthma home, the team should see their inhalers. It is very, very crucial because if you discharge a patient home without the inhaler and spacer, trust me, they'll come to the clinic and you see them after a month and they have nothing. They haven't been using any inhaled corticosteroids. They haven't bought it because their aim was to go home. So that is very important. So practically what I do is as soon as you are admitted and it's confirmed you have asthma, if you don't have an inhaler and you don't have a spacer, we start writing from day one so that by the time the patient is going home, if he's going home that day and comes in the morning, at least by evening, you have a plan of what to do. If he's going home the next day, he would have gathered some funds to be able to buy his discharge inhaler and spacer home. Ideally, it would have been good for the district hospital or donors to donate some free spacers and inhalers because they can be expensive. Then the controller, initiate or increase daily inhaled corticosteroids. So this patient has come with an acute episode. Let's remember that late phase of asthma exacerbations, you actually want to prevent the late phase. So in some patients, you may slightly increase their daily inhaled corticosteroids. So let's say if they were on 1 puff daily for about the next 7 to 10 days, you increase to 1 puff twice a day, then they can step down because you are going to follow them up within that next week to know whether they are still they are better or whether they've had issues post-discharge. Then check risk factors and work on the modifiable risk factors. So if there was a relative smoking at home, that's modifiable. Talk about the smoking, if they were exposed to any irritants or triggers. Sometimes domestic smoke can be the irritant. Some of them may have painted their houses recently, or they may have moved to a new area that has dust. So if there are things you can change, you change them. Inhaler technique and adherence, I have found to be one of the most modifiable risk factors. If you are able to get them to practice the technique, practice it over and over again with you in the hospital, the outcomes are way better. And so for our patients, it's important that even when they've gotten their inhalers and spacers, you don't wait till the plan from the team is discharge patient today, and then that is the first time they are handling the inhaler and the spacer. For the children who are less than 6, some of them are actually scared of the spacers. So what I do is I just give it to them to play with. And so for that day, they are playing with the spacer. They find it as something that's attractive. You start putting it to their noses. You start teaching the mothers or the caregivers how to use it. By the day they are going home, they have learned it. You can even use an empty inhaler to teach them how to use it, and then test their technique before they go home. Ensure that the patient has the appropriate inhaler and spacer. Then short-term follow-up, so about 1 to 3 days follow-up, or some would say 5 to 10 days, the patient should be seen. That short-term does not necessarily have to fall within your asthma clinic day. You may want to follow up the patient again just to see if the technique is fine, whether the patient has had any recurrence after that initial episode, and whether there are any other things to tackle before their next follow-up date. The action plan should be clearly spelled out, and patients who need specialist referral should be referred, especially those with previous severe or life-threatening exacerbations, or those with repeated emergency visits for asthma or comorbid atopic conditions. And my last 2 slides, the action plan. This is a recommendation from Gina. For children under 12 years, initiate or increase an inhaled corticosteroid containing treatments. It can be fluticasone, it can be budesonide, it can be beclomethasone. Then for the adolescents, the reliever, so it depends on what you are using as your maintenance for the adolescent. So if the adolescent is using a budesonide formoterol or a formoterol containing inhaler, then you can increase the reliever as needed. I must mention here that for adolescents with acute asthma, which is mild, or if you want them to use the reliever as needed, they should not use more than 12 inhalations in 24 hours. So Gina recommends that if they have a mild episode at home and need to use an extra reliever out of their normal maintenance. So for instance, the patient is using budesonide formoterol 164.5 microgram, 1 puff twice a day. If he has a mild asthma episode at home, he uses 1 puff as a reliever at a time. After a few minutes, if he doesn't have, he hasn't seen much of an improvement, he is allowed to use another puff. But we do not want him using more than 12 puffs in a day. And that 12 puffs includes both his maintenance dose and the reliever dose. Then if the patient is less than 12 years, there are some 6 to 12-year-olds who are also on SMART therapy. Now, the if a patient is less than 12-year-old, then the formoterol containing inhaler, which is used as an anti-inflammatory reliever, should not exceed 8 puffs in a day, and you use 1 puff at a time. Now, if the maintenance inhaler for the patient is an ICS formoterol or an ICS SABA, continue his maintenance dose of the ICS or ICS SABA. If the reliever is a short-acting beta agonist, increase the ICS containing dose for at least 1 to 2 weeks. So here I must say that if the patient is on a salmeterol fluticasone combination, then his reliever is a short-acting beta agonist. I must just mention that if the onset of action of salmeterol is very slow, the onset of action of formoterol is comparable to salbutamol. That is within a few minutes, up to about 5 minutes approximately. So that's why that is used as a reliever therapy with the inhaled corticosteroid. But if you have salmeterol fluticasone, you cannot use that as the reliever therapy when the patient has an episode. So SABA would be the reliever for the patient at that time. That means that we can increase his dose. If he was on 1 puff, you can go to 2 puffs for the next 1 to 2 weeks. Newer studies have also found that for patients in some centers, they quadruple the dose of the inhaled corticosteroid. But they've realized that you do not get much improvement with a quadruple dose, but then you'd be exposing the patients to the long-term effects of steroids, though most of the steroid inhalers are supposed to give the minimal systemic side effects. Then before my last slide, I just want to say that when we are given the medications in asthma, let's remember their side effects, okay? So for salbutamol, you may have some increase in lactate. So if you do the blood gas analysis, the lactate may be increased at a point. They may also have palpitations, tachycardia, which we should look out for, hypokalemia, okay? And then for the inhaled corticosteroids, they may have oropharyngeal candidiasis and some dysphonia. Magnesium sulfates may have hypotension. So when they are on magnesium sulfates, especially if some have to go on to magnesium sulfate infusion, then the blood pressures should be monitored. They may also vomit after magnesium sulfate infusions or may have nausea. So those are some of the things we should look out for. Then the last slide is on an asthma action plan. It can be very simply done. You do not need you can use the Excel sheets like I said. You can color code, and it also is individualized because some of our patients may not be literate. So if you give them this sheets and say green zone, yellow zone, look out for this, they may struggle. So we look for innovative ways. For those who are not literate, one thing you can do is tell them the next time you are coming to clinic, come with a relative who can read. And then you teach the relative, and then that person can help at home. Sometimes if you have the asthma diary, what you do is you can use the color of the inhaler. So if it is the reliever they have to use, you color that portion blue for them. If it's the maintenance therapy, you can color brown or red so that they can match the inhaler to where they need to give the medications. The children may be literate and their parents may not. So if the children are usually above 7, they are they are the best to actually engage when you are educating, because some of the children would actually come and tell you that maybe mommy doesn't do it so well for me. And when you actually you check their inhaler techniques, the children are doing it better than the parents. So the zones are just telling us what to do. So usually the green zones mean that the patient is well and would just need to continue with their maintenance therapy. The yellow zone means the patient is unwell and you may need to step up maintenance therapy and use a reliever at the point, but now be on the high alert that he may or may not be admitted. Then red zone is obviously rush to the hospital, but whilst rushing, what do I use as my reliever and what do I do with the controller medication? So on this note, I'd want to summarize by saying that acute exacerbation of asthma must be promptly identified and categorized according to severity. First-line medications include salbutamol and ipratropium bromide. Monitoring of patients with acute asthma is very important. And I want to say thank you for your audience. Thank you very much. And over to you, MC.
Thank you so much, Dr. Hilary, for the enlightening and the informative presentation. I believe the way forward is to get our asthma teams built in the district hospitals, especially in the Volta region. Thank you so much, Dr. Hilary. Please, at this juncture, I would encourage everyone to visit the chat box for our evaluation forms and then complete them. I would like to invite Dr. Yanka to facilitate our question and answer session, please. Dr. Yanka, please, you have the floor. Hello, Dr. Yanka. Okay, Sir Jonathan, please, would you kindly take the question and answer session for us?
All right, thank you. Please, if you have any question, you can raise your hand and then ask. But then we have some in the chat box. So whilst people are putting their pens on their papers, let me read the ones in the chat box. So the first one is saying, do you suggest parents get their personal nebulizers at home?
Okay. Thank you, Dr. Jonathan. So I see it's a recurring question in the chat box. So it's a good question. I've had this a number of times. So parent recommendations, we do not recommend patients get their nebulizers at home. In fact, it's something we are pushing for clinicians not to be prescribing. Because remember, I talked about the side effects of short-acting bronchodilators, the overuse of SABA. So what happens at home is they know that they have Ventolin. The least thing, the child has a flu, they give Ventolin, they nebulize. The child has the exacerbations, they nebulize. And because they are nebulizing, one, they have this false believe that the child is improving. They are not listening to the chest. They do not know what the oxygen saturations are. It's actually, some studies have found some increased morbidity with that. And then the overuse of short-acting beta agonists can actually worsen the bronchoconstriction. So they come into the hospital much worse than they would have if they were not using the nebulizer. Then the metered dose inhalers are as effective as the nebulizers at home. So rather, we encourage them to use the metered dose inhalers with a spacer, or for those who are using the dry powder inhaler, remember that if you're on SMART, that's a single maintenance and reliever therapy. you are already on a combined treatment. So that patient is even benefiting from budesonide, which is a corticosteroid, which is going to even help mitigate late phases of an acute asthma exacerbation, as opposed to a patient being nebulized repeatedly with salbutamol at home. The last thing is that let's remember that the nebulizer has its dead space as well. And when they are nebulizing, a lot of the drug goes into the air anyway. Some of the patients may be agitated. So the children we see it in the hospital all the time. They keep taking off the mask and we keep fixing it back. When they are home, that may be happening, but the parents just has this false feeling of I'm nebulizing. So it's something we do not encourage. So whether nebulizing with salbutamol at home or nebulizing with salbutamol, ipratropium bromide, and budesonide at home, we don't encourage it. So we'd rather do that in hospital. And like I said, for the mild to moderate ones, in some centers, if the patient comes and it's a high flow facility, you have something that you call a patients on the bench or patients in the queue. So even amongst the emergencies, the ones that are not the ones that are less severe are started on metered dose inhalers with their puffs whilst in their queue. There are some that have successfully been discharged home even without having been nebulized in the hospital. So we discourage that a lot.
All right, thank you. The key word there is that we don't recommend that. Thank you. The next question says, any special recommendation for the facilities in the district?
I'm not too clear about the question. Is it about building the clinic or is it with respect to the management of asthma?
I'm
Maybe
sure.
if Kingsley could.
Yeah. He should come back with the question. I think
Yes.
everyone is up. Mami Frema, kindly go ahead, please.
Hello. Good evening, everyone. And thank you, Dr. Hilary, for such a good presentation. I'm in a district hospital, Presbyterian Hospital, Agogo, and
Okay.
we have an asthma clinic, which is not too active as far as I want it to be. And one thing that I have been looking forward to was us getting a common educational material. Because remember in your presentation, you mentioned getting this, getting that, getting this to run the asthma clinic in terms of education. I want to know whether it's possible for our pulmonologists or those in charge of asthma to put something together so that we could all use the same materials for education, use the same protocols, something that we can have to make running the clinic quite easier. Because right now it's a headache for me. When I started my clinic, I put together an SOP so that even when I'm not there, the clinic will still be functional. I'm the only pediatrician in my hospital. I don't know whether it can be taken up at the national level so that we could all have the same material. It will be brought down to us to make the work at the clinic a bit easier. I don't know your take on this. Thank you.
Okay, I think I didn't show my last slide. So the references, I think I forgot that bit, but the Ghana Thoracic Society has, sorry, let me close this box. The Ghana Thoracic Society has the 2023 guidelines on asthma. It also covers a lot of the things I've talked about. It's the practical things of building the clinic that is not there, but it's something we could look at. There are I believe there are members of the Thoracic Society here, and other pulmonologists and specialists. Together with allergy, we can put together something. I think it's a discussion we can have in due time to make it easier for everybody. Thank you so much for that contribution. So another thing that can help you, whilst you being the only one in your district, is also to get a nurse champion, because the education is maybe, I would say, one of the major things in the clinic. So if you are able to train somebody on how to teach the parents how to use the inhalers and spaces, and then you have the plan or the guideline and clear referral as to what to do to refer to the next facility. It also makes your work a bit easier, because then even when the patients are seen by another doctor and the nurse is on duty, they can cross over and then help with the training of the patient. So you need that with the flow of work. That last slide I put there, that linkage is really necessary, even within the hospital, to know who can help out when you are not around.
All right, thank you. So the next question is saying, aminophylline was not mentioned. Can you throw more light on it?
Okay. So aminophylline is something I would say I intentionally took out or did not include, because now aminophylline is not one of the main recommendations anymore in life-threatening asthma, mainly because of the side effects of aminophylline and the safety profile. So if they're on aminophylline, they could have arrhythmias, which can be fatal. So seeing that there are safer options, magnesium sulfates, and then salbutamol. Salbutamol after magnesium sulfate is what is recommended, but magnesium sulfate is the next line of action if the combined ipratropium salbutamol nebulizations are not working. I would say that I used to use aminophylline some years back, but I haven't used aminophylline probably in the past 3 or 4 years for asthma, because it's not something that's recommended, and I've practically seen great improvements with IV max sulfate. So that is what's being recommended. So a number of protocols are taking aminophylline out of their protocols. Okay. Some people have tried nebulized magnesium sulfate, but looking at the studies, it doesn't seem to be as effective as IV max sulfate. So, but if that is the only thing you have in your facility, which can happen or which happens, then you can give IV aminophylline. So you can give the 5 milligram per kilogram start, and then continue with 1 milligram per kilogram per hour with aminophylline. So you can give the loading dose and then do the maintenance dose if that is what you have. But if you're in a facility that doesn't have an ICU and you are going to start aminophylline, it means that this patient has to be referred. And whilst waiting for referral, you can continue the nebulizations.
All right,
And let
thank
me
you.
just state that whilst you are continuing the nebulizations, you can nebulize with oxygen. So sometimes we wait and the patient has severe or life-threatening asthma, and we nebulize with a machine, but we realize that for that 1 hour, the patient is actually off oxygen, but hypoxic. So you can use oxygen to drive the nebulization instead of connecting the face mask to a nebulizer. So that's one practical thing you can do whilst waiting to refer.
All right, thank you. Someone is also asking if we can give hydrocortisone while the patient is on nebulizer.
Yes, you can give hydrocortisone when the patient is on a nebulizer. So mild to moderate, they don't need hydrocortisone. They can have oral prednisolone. Life-threatening, definitely we should give hydrocortisone because the patient may not be in any position to take orally. With the severe ones, you can give prednisolone or hydrocortisone. So if the patient is unable to swallow, go ahead and give IV hydrocortisone, and it can be done whilst they are being nebulized.
All right. So another question to the same hydrocortisone says, can someone do both the hydrocortisone and then budesonide together?
Budesonide.
Yeah.
Okay. So that was what I talked about with the various studies. So you can do both hydrocortisone and nebulized budesonide together. It's just that we have so many conflicting studies now about whether one, just the hydrocortisone has whether the combined nebulized and systemic corticosteroids are actually superior to just the systemic corticosteroids. A number of studies have found some benefits in terms of hospitals, duration of hospital stay. Some have not found any benefits. So really it's you can decide to do both. And actually, a number of facilities do both for severe and life-threatening asthma.
All right. Thank you. I think there is another question from Luis. Luis is saying, the teaching says asthma can be diagnosed after 6 years. In such cases, if you have a child less than 6 presenting some asthma-like symptoms, how do you properly diagnose them? And then the second one is, does ICS play a role in diagnosing asthma in children less than 6? And then his third question also says, patients with heart failure with severe asthma in a district setting, do you recommend we still use salbutamol if that's the only available treatment?
Okay, so I'll take the first question. I think because I was running out of time, I didn't talk much about those less than 6 years. Yes, you can diagnose children less than 6 years with asthma. So if you look at the GINA treatment guidelines, there's a beautiful table or a summary there. Okay, so let me just summarize for you. So if you have a patient, or let me say the less than 6-year-olds, we'll call them preschool wheezers. And preschool wheezers may or may not have asthma. What can guide you to know whether a preschool wheezer is likely one with asthma or not is that you look at certain factors. Is this child having symptoms in between episodes of respiratory infections? Does this patient have symptoms with triggers? So other triggers, dust, smoke, irritants. Does this patient have comorbid atopic conditions? So allergic rhinitis, eczema. Does the patient have a positive first-degree family history of asthma? So when it comes to asthma, we are not talking about grandparents, uncles, aunties. We are talking about siblings, parents, and if in the case of adults, their children. So first-degree history. Or does this patient's symptoms, do the symptoms lead to hospitalization? Or are the symptoms more than 10 days whenever they have it? So they have a respiratory infection, they are wheezing, they are ill for more than 10 days, or are they having more than 3 episodes in a year? You combine a number of those. So the more it's like so the GINA calls it a probability risk of asthma. So the more you have those in that category, the more likely it is that this child who is less than 6 has asthma, as opposed to a patient who is less than 6, but then has infrequent episodes, maybe 1 or 2 in a year. Each time he has that wheezing, he only has it when he has a respiratory infection. In between respiratory infections, there's nothing, no exercise-induced wheezing, no seasonal symptoms. The child is otherwise fine. That may not likely be asthma. So these may they may progress with time. And so I always call them the time will tell group. As they go, you may know whether really, yes, it's asthma I'm dealing with. But if they have more of those risk factors I talked about, you would treat them as patients with asthma. Now, for those that we are not too sure, they have some of the symptoms, but they are not prolonged. They don't have the prolonged hospital stays. You are not really seeing atopy in them. There's something we call, so it goes down to the next question you are asking me. It boils down to something we call using a trial of inhaled corticosteroids. So here, this patient should be with a specialist by this time who can manage asthma. Here, you would give a trial of about 6 to 8 weeks, usually 3 months. Okay, some would say 6 to 12 months. So you give a trial of daily corticosteroids for 3 months. But then within those 3 months, you're looking at whether the patient is still having episodes or not. If the patient is episode free, you stop the inhaled corticosteroids, but you do not discharge from your clinic. You follow up the patient and see whether they have a recurrence of the symptoms. If they do, it is very likely they have asthma and need to go back on the inhaled corticosteroids. If within the 3 months the patient is still having his symptoms, he may or may not have asthma. He may have other mimics of asthma. So the patient may have reflux. The patient may have cystic fibrosis. The patient may have TB, for which he's wheezing. You start looking for other differential diagnoses. So you are going to assess the patient completely. Is he failing to thrive? Is there other signs of clubbing? What other symptoms are you seeing? And then re-diagnose or go back and look over your diagnosis again. So they are a special group that is also not a one-size-fits-all group. Okay. Then the third point with patients with heart failure with severe asthma in a district setting. I think if salbutamol is all you have, use it, because that's actually the first line anyway. So if you have nothing to use the salbutamol. If the patient is having hypokalemia from the repeated salbutamol doses, we can now put on maintenance potassium. Okay. So I think that's for his question. And just to mention that I have the Ghana Thoracic Guidelines on Asthma reference here as well. And then we have GINA 2024-2025. There's Allergy Foundation of South Africa, some material on that too, and then the other references. So there are good guides to make things easier for us as well.
All right, thank you, Doc. I think people are also of the view if they could get the slides. So
I
maybe that
think
one will
the recording is available, so we can use the
that's fine.
recordings and you can take screenshots of the recordings.
That's fine.
I believe it was recorded because I actually saw the prompts when you were, and it's on YouTube, you mentioned.
Yes, please.
So they can go over and play and then take shots of that.
All right. Thank you very much. So I think we are running out of time, and so I would like to give the floor
Sorry,
to Dr.
can I just I've seen 2 questions here. Maybe I'll quickly They
Okay,
said,
that's
what's
fine.
the role of oral salbutamol in asthma management? So oral salbutamol is not recommended because remember that oral salbutamol, you now have to get it metabolized. So now the inhaled ones are directly into the mucosal linings. So we do not recommend oral salbutamol anymore. And then mag sulfates dose and mechanisms of action in pediatrics. So mag sulfate works on the prostaglandin E2 receptors, and it helps in bronchodilation as well. The dose is 25 to 50 milligram per kilogram in 20 mils of normal saline over 20 minutes. And is that part of the protocol currently? Yes, it's part of the protocol for the GINA treatment guidelines.
All right, thank you very much for. So, Dr. Daniel, if you can hear me, over to you. Hi, Dr. Daniel. Please, if you can hear me, over to you.
Okay, thank you very much.
Anyway, if you are now joining us, we are having a discussion with Dr. Hilary Yando. She's taking us through management of asthma and how we can have asthma clinic in our district hospitals. And so we have a whole lot of things. The recording would also be shared with us. We are taking questions and answers. She just finished answering. And so, Dr. Daniel, if you can hear me, over to you. The floor is yours now. Hello, Gloria. If you can mute Dr. Daniel. He said he can unmute himself.
Great. Thank you, Jonathan. And Dr. Hilary Ando, thank you so much. Pediatric Society, Volta branch, we are very delighted and excited to have this very much well-presented discussion. And all we can say is that Maunaya Okakaka.
Thank you so much.
Thank you so much, Dr. Hilary. There are more things I want to say about her, but we'll leave it for another meeting. I would kindly ask all of us to please stay on. We are having a very another part of the presentation. This is not going to be very long. It's a pharmaceutical company, and they'll be talking to us very briefly. And if you have any questions, we would ask. We would ask that the presenter would please make available his number in the chat box as he is preparing to share his slides. So if members have any other questions, they can privately reach out to him as well. So the farm from Cipla, if you are on, please share your slide. And please remember to kindly fill our evaluation forms for us as well. We really need this to plan future events. Dr. Hilary Ando, once again, thank you, and it was a great pleasure listening to you. So,
Thank
Cipla, if you
you
can
very
hear
much.
over. Thank you.
Okay, hello, Dr. Daniel. Thank you so much for the opportunity. And please, am I audible enough? Hello.
Loud and clear.
Okay, thank you very much. And my name is Fifi Gazy. I'm a pharmacist and a medical representative with Cipla. And Cipla has been in Ghana for close to 2 years. And for the past 2 years, we've been working with the mantra caring for life. And we've been caring for life in different aspects. We have some initiatives and projects that we have undertaken. As pediatricians, you would be interested in this one, which is called Miles for Smiles. We have been able to sponsor and fund close to 1 million cleft surgeries all over the world through two runners that have been walking around. In Ghana, we have been able to fund a few cleft surgeries at Eastern Regional Hospital, Volta Regional Hospital, and some at Kolebu. So to talk about the substantive matter, thank you so much. Before I proceed, I want to thank Dr. Hilary Andor for the very insightful presentation. There's a lot to learn from the presentation she delivered. As part of caring for life here at CEPLA, one of our key therapeutic areas is respiratory, and we have a unique proposition for asthma, and with reference to the guidelines. So Dr. Hilary actually touched on this, the concept of SABA over-reliance, which I'm not going to mention, but this is what the concept of SABA, the concept of SABA over-reliance paints. We are making sure that in Ghana, there is a very high consumption of SABA inhalers, and it is important that we continue to educate our patients that that do more than 2 inhalers in a year are at risk of exacerbation, and patients that do 1 inhaler every month are at risk of mortality. And so since we have spoken about the guidelines, we want to just find out what method or what device is best for the treatment of asthma. When it comes to the treatment of asthma, we have different types of devices. We have the PMDI, patient metered dose inhaler. We have the DPI, the dry powdered inhaler. And this graph here shows the inhaler and the amount of critical errors that is likely to be made by the patient. So we have different types of two main types of errors when it comes to patients' usage of asthma inhalers. First, we have the critical errors. Critical errors are inhaler-specific errors. So when you are using a PMDI, there's a kind of error that you are more likely to make. And when you are using the discus is the round inhaler. I don't want to mention the brand. And then when you are using the Tebihaler, all of these inhalers have specific mistakes. And then also we have generic mistakes. Generic mistakes or generic errors are errors that are not inhaler specific. So we look at the patient not holding their breath before inhaling the content of the inhaler. And then also patients not holding their breath after using the inhaler for 10 to 15 seconds. And then also patients not exhaling completely before inhaling the substance of the inhaler. But when it comes to the critical mistakes for PMDIs, the discus, the hand inhaler, and the Tebihaler, they are all different. For the Tebihaler and the discus, which is the DPIs, the problem is that most patients are not able to inhale very well. The inspiratory flow force for the use of a Tebihaler or a discus is 60 liters per minute. And most asthmatic patients are not able to inhale more than 60 liters per minute. Now, when it comes to the use of these DPIs, the inspiratory flow force is the problem for most asthmatic patients because they can't pull the contents from the inhaler. Now, when it comes to the PMDI also, the PMDI's problem is the breathing and actuation coordination. So in this donuts graph, you can see the percentage of errors, percentage critical mistakes for each of these types of the inhalers. So you have the PMDI, which is the lowest, so 12%. So from this graph, we can see that the PMDIs, in using patients that use the PMDIs are less likely to make critical mistakes. So these are guidelines. Doctor spoke about these guidelines well, and we have the ICS Ometerol used as a reliever over here, and then also we have ICS LABA also used as the maintenance drug. So this is the guidelines for children under 5 years. So for each of the guidelines, there are different types of ICSs used or inhaled corticosteroids used. So for if you can see my mouse, I'm pointing you to the fluticasone propionate PMDI. So let me put this somewhere. Okay. So we have the fluticasone propionate PMDI, low dose 100 to 250 micrograms, and then medium dose 250 to 500 micrograms, and then higher dose greater than 500 micrograms. And then also we have the budesonide DPI or PMDI. We have 200 to 400 micrograms for low dose, 400 to 800 micrograms for medium dose, and then greater than 800 micrograms for high dose. Then we also have budesonide and then fluticasone as one of the ICSs of choice for the use of for management of asthma in children between 6 to 11 years. So this is the unique proposition that Cipla has for asthma. We have our Foracort inhalers, which contains budesonide formoterol, and then Serocort inhaler, which contains salmeterol with fluticasone. So the Foracort inhaler comes in 200 micrograms, and then the 400 micrograms canister. So the reasons why we would go for the 200 micrograms, because one, the GINA recommends that when it comes to SMART therapy, Foracort budesonide formoterol can be used both as a reliever and a maintenance drug. And we have data that shows that it significantly reduces exacerbation rates as compared to ICS plus SABA. And also, when it comes to reduction of the rates of COPD, Foracort does very well. Also, Foracort is a PMDI, more importantly, a PMDI. And as I said earlier, PMDIs have less critical errors and probability. So it is best to recommend PMDIs for your clients if you want to reduce the incidence of critical errors. Also, most of your clients probably are on salbutamol inhalers, and most of the salbutamol inhalers come in the form of a PMDI. So switching from a PMDI salbutamol inhaler to a PMDI Foracort, that's budesonide formoterol inhaler, would be easier because the patient already knows the kind of canister and how to use it. So we also have this inhaler, which is the first of its kind in Ghana. This inhaler is Serocort, and the type of inhaler it is called a breath-actuated inhaler. Serocort Syncrobit comes in 125 micrograms and then 450 micrograms. At the moment, Serocort Syncrobit is at Whole Teaching Hospital, and it is a breath-actuated inhaler. The advantage the breath-actuated inhaler comes with is that it eliminates the breathing and actuation problem that most PMDIs come with. So breathing and actuation coordination is perfect when it comes to the use of breath-actuated inhalants. You don't have to actuate, just put it inside your mouth and then breathe. So we would watch the video. Watch a short video on how to use the breath-actuated inhaler.
Hello, Fifi. Please, are you done?
No, please. I'm showing a video. I don't know if you can see it. I'm just showing how to use this inhaler, this particular inhaler. I don't know
Okay.
if you can see the inhaler, the video playing.
Yeah, I can see.
Yeah, so it's a short video. Yeah. So that's how easy it is to use the Synchro Breathe inhaler. We actually have a lot of the information material that Dr. Hilary spoke about. We have the asthma control test. We have the asthma diary, and then also we have an asthma symptom tracker. These are materials that will help every asthma clinic and it will help your patient track their symptoms and help the patient understand whether they are actually getting whether they're actually having their symptoms under control and whether the incidence of exacerbation is reducing. So a very big thank you to the Paediatric Society. I am very grateful for this opportunity that you have given to us. This is the CEPLA team, and you will see us very soon. We have at the moment we are working hard to get for our courts. We are working hard to get for our courts as the regional medical stores, and we have several at Full Teaching Hospital. But if you are looking for Serocot or Foracot in any of the shops in Hu, we are at TT Pharmacy and then Top Up Pharmacy and also Lena Pharmacy. Thank you very, very much. And I'm very, very grateful for the opportunity given. Thank you.
You are welcome. So there is a question for you asking how much was the cost of it?
So thank you very much. So the Foracot 200 micrograms is covered by insurance. The Foracot 250 micrograms is also covered by insurance. That is the first thing to note. Also, the 200 micrograms goes to 82 cedis. That is the wholesale price. So it shouldn't go above 110 cedis when you go to the retail shops. And then we also have the Serocot 250 micrograms, which goes for 257 cedis. So it shouldn't go above 300 cedis. But the good news is that it's covered by insurance and it's served on insurance at Full Teaching Hospital.
All right, thank you very much.
Any more questions?
I think that's the only question for you.
Okay, sure.
Okay.
Thank you very, very much for having me.
You are welcome.
Okay.
Before we go on with the vote of thanks, Dr. Hilary made a correction. It's in the chat box. She said correction on the question on the magnesium sulfate. I think I may have said prostaglandins receptors. It rather blocks calcium influx into airway, smooth muscle cells, and subsequent muscle relaxation and bronchodilation. So she was making a correction to what she had said earlier. All right, Dr. Daniel.
So if I can be heard, thank you so much, Sipla. It's very comforting to note that the medications are on insurance, and we'll definitely make do with what we can. So thank you once again. And for all who have joined us, this is Paediatric Society of Ghana, the Volta branch. We are very happy to have you join us. Next month, God willing, we'll be having an institutional presentation. It's going to be a case presentation from one of our institutions. It's not Whole Teaching Hospital. It's not Volta Regional Hospital. So watch out for the flyers and please do well to join. And then please share the link so that your other colleagues would also join. On that note, I want to say a big thank you to those who have been able to put this wonderful meeting together. And just to say thank you from Paediatric Society of Ghana as well. Jonathan, over.
Thank you, boss. Before we take the closing prayer, I would like to remind all of us as members that we are to pay our dues 120 cedis for associate members and 240 cedis for members, and that is for the whole year. And so if you have not done that, kindly contact myself, Dr. Daniel, or Dr. Saba to make your payment. We will have the Momo line of PSG Volta sent to you to do that. I call on Dr. Saba to give us a closing prayer.
Okay, shall we pray? Father, we thank you for a very fruitful deliberation, fruitful learning session. We ask that to impact the care we give to our children in the region and beyond. We ask that you would bless our members' pockets so that they'll be able to come and pay their dues so that we can be able to organize more of these sessions for them. This and many other things we ask through your Son, Jesus Christ. Amen.
Amen. This looks like a treasurer's prayer.
Exactly. I agree with you. All right, see you.
Amen. Thank you. Thank
Next
you,
month,
Madam
same
MC.
time.
Thank you.